Welcome to the recorded version of Trauma-Informed Care for People Living with Dementia from April 10th, 2018, part of the National Alzheimer's and Dementia Resource Center webinar series sponsored by the Administration for Community Living.
Thanks, Steve. Welcome, everyone, to the webinar today on Trauma-Informed Care for People Living with Dementia. In this webinar series, as you heard from Steve, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're really pleased to have all of you in attendance today. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome.
Hi, everyone. I want to thank you so much for attending this very important webinar, and to Matthew and Andrea for sharing their knowledge with us. We've had great response to this webinar, and we're very much looking forward to learning what they have to share. So with that, thank you again, everyone, and to our presenters, and back to you, Sari.
Great. Thanks, Erin. For today's webinar, we are hearing from Matthew Yoder and Andrea Korsunsky. Matthew is a clinical psychologist who works for the National Center for Post-Traumatic Stress Disorders as a consultant in the Post-Traumatic Stress Disorder Mentoring and Consultation Programs. He came to the National Center for PTSD from the PTSD clinical team at the VA Medical Center in Charleston, South Carolina, where he worked as a staff psychologist providing evidence-based treatments to veterans diagnosed with PTSD. Andrea is the director of the Seniors at Home Center for Dementia Care and has worked with older adults with memory loss for more than 12 years. We welcome both of them today, and we will get started with Matthew Yoder's presentation, and I will just turn it right over to you.
Okay, thank you. All right, so yes, my name is Matthew Yoder, and I work now for the National Center for PTSD, and part of what I want to do today is give you all some information about what we do here at the National Center and have you bookmark us for as a resource moving forward in the important work that you do. So that's me, that's our logo. I do want to talk a little bit about various aspects of trauma-informed care today, and much of what I have to say will relate directly to veterans, but I also think and hope that what I have to say cuts across clinical populations and applies to clients who are not veterans as well. So you're looking here at a definition of trauma-informed care. We all know that there are many different types of trauma: military, post-military, childhood, natural disasters. And on some level, most of us are probably impacted by trauma. As providers, it can change the way we view the world. Listening to stories of things, bad things that happen to people can change our sense of how the world works. Survivors of trauma certainly are often impacted by their traumas, and family members of traumatized people can also be impacted. Knowing that something unthinkable has happened to their loved one can change the way they think and act in the world. And on some level, you know, this makes sense. As humans, we really have to develop ways of managing the reality that bad things can happen. And if we didn't, we would, you know, be paralyzed by the fear of what might occur. So, you know, how we formulate our beliefs around survival and suffering and bad things that happen makes a difference in how we respond to trauma. And some of these responses can be adaptive, they can build safety and trust. Others can usually unintentionally get in the way of recovery and contribute to impairment and problems that people have post-trauma. So I think it's worth just to sort of broadly speak about trauma a little bit. In terms of trauma-informed care, probably the most important part of trauma-informed care, if there's one thing to take away today from my part, is that being educated about what trauma is and the impact it has on you and your clients is essential to providing trauma-informed care. So knowing what to do if you suspect trauma may be impacting yourself or your clients, and knowing how to recognize the signs of that are some of the things I want to talk about today. So it's essential when talking about trauma-informed care to get a good sense of what we mean by trauma. the word trauma is often used in our culture, in our language, and can mean different things to different people. I often hear people talk about being traumatized by things like a bad haircut, traffic jam, or even a breakup. You hear that word being thrown around. And while those things can be very stressful, they're not what we mean when we use the word trauma clinically. For our purposes, we use a DSM-5 definition of a traumatic event, and that's the Diagnostic and Statistical Manual, 5th edition, for trauma. And you see the definition here on the slide. We tend to call these traumas big T traumas as a way to just sort of distinguish them from other events that people may be talking about when they use the word trauma. So you'll see here that trauma can happen in different ways. So the most common way can be through direct exposure, can also happen by witnessing in person, or even learning about it happening to a close family member or friend. Experiencing difficult, extreme, diversive details of a trauma in a work-related setting is also a way that some people may be exposed to trauma. And I think that number 4 there has particular relevance to folks on the call today. So this is the definition of what we mean by trauma. And you see there up at the very top, exposure to actual or threatened death, serious injury, or sexual violence. That's a fairly narrow definition and doesn't include many things that clients find very, very stressful. In fact, some stressful events may actually be more impacting than traumas. You know, finding out that a partner has cheated on you, or you know, things like that may actually be very, very stressful at any given time, but they wouldn't meet our criteria for DSM-5 trauma. So just wanted to highlight that definition of trauma. A couple more things about trauma, PTSD, and resilience. Not all trauma survivors develop PTSD, and in fact, resilience, or the lack of psychopathology after trauma, is the rule. Most people you encounter in your daily life will have experienced a trauma during their life, and yet only about 8% of Americans will experience PTSD at some point in their lives. So we know that the majority of people who live through a trauma will not go on to develop PTSD. Rates of PTSD are higher for groups that have served in the military, and other groups are also at higher risk for developing PTSD after trauma. People who have less resources after trauma, for example, homeless people, and other folks who have less resources at their disposal, especially social resources. It's also worth noting that a significant number of people who report living through trauma report benefits of surviving trauma. We call this post-traumatic growth or resilience. And you know, that's something to also keep in mind as you're working with people who have experienced trauma. We tend to focus in mental health on the negative impacts of life events, but it's also worth noting that with trauma, many people do report benefits and good things of surviving that trauma. So that's something just to highlight here. Okay, so given that trauma does not equal PTSD, I did want to talk a little bit about what PTSD is, because it's one of the most common things that can happen, negative things that can happen to people after trauma, and it's something that you may observe in the clients that you work with, and it's going to be sort of the focus of the next part of the presentation here, because as hopefully you'll start to gather, one of the most important parts of trauma-informed care is being able to recognize the impacts of trauma, and so knowing about PTSD and how your patients may be suffering from PTSD is important. Oops. Okay, so in order for someone to have PTSD, they have to survive one of those big T traumas that I mentioned. Also, the other sort of hallmark symptom of post-traumatic stress disorder that I think separates it from many other mental health diagnoses is this letter B here, intrusive symptoms associated with the traumatic event. Usually we're talking about things like nightmares, memories that pop into their mind when they don't want them, memories of the event. Intrusive symptoms, that's what we're talking about, thoughts and memories that sort of pop in a person's mind in an unwanted way that are related to the trauma. And then there's typically avoidance of stimuli related to the trauma. So when people live through a trauma, there's all sorts of associations that are made in the mind about sort of how the world works and certain triggers out there in the world. And typically with PTSD, there's avoidance of those stimuli. Also, negative changes in cognition and mood. So basically here, you know, in people who have PTSD, living through their trauma changes the way they think about the world and the way they feel in the world in a negative way. PTSD also includes changes in arousal and reactivity. So this can look different in different people, but often it manifests like irritability or shortened fuse for anger, hypervigilance, sort of being constantly on guard for things that may be at harm or danger. But this symptom cluster here is talking about the way trauma can change reactivity. And then we have other symptom clusters, other characteristics of PTSD that the symptoms need to have lasted more than a month. There needs to be significant impairment, and the symptoms cannot be due to another medical condition. So that's PTSD. A couple of things to highlight here with PTSD, common reactions, looking globally at the effects of trauma. Some of the common reactions that we see are, and again, these are just a few examples. There's a wide range, a wide spectrum of reactions, but feelings of guilt and shame are very common post-traumatic reactions. Also aggressive behavior and suicidal thoughts. So I sort of pulled these out because I think they are types of symptoms that may be prevalent in the populations that you're working with. And in particular, I'll talk about this in a minute, but suicidality is important because for some clinics and for some treatment centers, suicidality or having suicidal thoughts is an exclusion it blocks them from getting in. It's an exclusion to getting into the clinic. And so if it's a symptom of the disorder the person's seeking help for, that's a problem. And so trauma-informed care in your setting may look like reevaluating your inclusion and exclusion criteria for who gets into your clinic, and recognizing that suicidal thoughts may be actually a result of trauma, and that can respond to treatment. Also, aggressive behavior, escalating aggressive and assertive behavior can often present itself in patients with dementia, and being able to recognize, again, that those symptoms may be a result of trauma as opposed to dementia can be an important part of trauma-informed care. So with the release of DSM-5, the term dementia has been subsumed by the category or the diagnosis of neurocognitive disorder. I'll be using that term interchangeably throughout the rest of this presentation, NCD, neurocognitive disorder with dementia. The neurocognitive disorder, understandably, is a broader category, but the relationship between PTSD and neurocognitive disorders is bidirectional, represented here by the arrows, and the pathways that lead from one to the other are relatively unclear at this point. For example, in one study of veterans over 55 enrolled in VA healthcare, those veterans with PTSD were between 1.7 and 2.31 times more likely to obtain a first-time diagnosis of dementia in the following 7 years than those without PTSD. So that's really interesting. This is a first-time diagnosis of dementia, and those who had PTSD were significantly more likely to obtain that diagnosis. We also have a study that suggests those with neurocognitive disorder have worse symptoms of PTSD than those without. And neurocognitive disorder or cognitive impairment in general. So you know, the arrow goes the other way as well. We also know that PTSD and neurocognitive disorders like dementia often share common risk factors. So mild traumatic brain injury, mild to moderate traumatic brain injury is a risk factor for both PTSD and neurocognitive disorders. Also, substance use disorders are risk factors for developing both conditions. So again, a trauma-informed care perspective underscores the importance of being aware that risk factors for dementia may also be risk factors for PTSD. So now that we've covered some basic information about trauma and PTSD, let's talk a little more about trauma-informed care. So who benefits from trauma-informed care? Who is it for? And in general, we think trauma-informed care can benefit and is for clients with PTSD and those without a diagnosis of PTSD. Veterans who have reported trauma histories and those who have not reported trauma histories but may have them. Also, it's an important component of trauma-informed care to be aware of the impact of trauma on staff and leadership in the organization providing the care. So trauma-informed care can assist everyone in understanding that our interactions influence safety and trust, working together in a manner that really doesn't re-traumatize, but builds transparency, safety, trust, control, common themes that impact traumatized folks. And also I think it's worth mentioning here that trauma-informed care also means not labeling someone as traumatized or as having PTSD simply because they do have a trauma history. If you go back to some of that earlier information I presented, living through trauma does not mean one is traumatized, and it certainly doesn't mean that one has PTSD. So sort of two messages here. Be aware of a trauma history and how it might be influencing someone, but also don't assume that just because someone has trauma that they have PTSD or that they deserve a label of some kind. Okay, so how can trauma-informed care lead veterans and I would say other clients of yours towards recovery? It's a good question. Couple key steps here, and I want to just sort of talk about this a little bit. This comes from SAMHSA, Substance Abuse and Mental Health Services Administration. So the first step is a commitment to creating safety and ensuring that services are derived from a place of compassion. Avoiding re-traumatization, and really in order to avoid re-traumatization, it's a term that we hear a lot in our work, and there's a lot of confusion in the field about what is re-traumatizing and what isn't. Many people seem to think that talking about, screening for, assessing PTSD or trauma symptoms is re-traumatizing, and it certainly is possible that happens, but the manner in which assessment screenings and discussions around PTSD symptoms or trauma symptoms occur make all the difference. So those discussions and screenings don't necessarily have to be traumatizing. And in fact, I would suggest that being able to avoid re-traumatization in someone who is traumatized means that providers really do need to be aware of what a person's trauma history is, so there needs to be some assessment or screening, and what is triggering for them. So you need to be able to talk about what a person's symptoms are related to their trauma history. This is generally not a linear process. It's an ongoing maintenance thing, ongoing self-assessment, ongoing assessment of your patients, attention to practices and policy. I think having good trauma-informed care woven into the practices at your setting is more effective than sort of trying to respond to every individual client from a trauma-informed care perspective. So making sure that good trauma assessment is part of your procedures, being aware of who's coming into your clinic, who's coming into your setting, who may have experienced trauma and may be impacted by those experiences is crucial. Some important elements, some key elements to trauma-informed care that cut across all models. Again, realizing the prevalence of trauma, recognizing how trauma affects all individuals working within the program, and then putting this knowledge into practice. So trauma does not only affect veterans, it does not only affect homeless people, it can permeate all areas of your organization. So the message here is assess and try to measure what those impacts are. It's also, thinking a little bit about the impact of trauma on providers in your setting. Many people think that it can be traumatizing for providers to work with people who have PTSD or who have a trauma history, and it certainly can be, but again, not necessarily. So one of the things that I really like about working with PTSD is that it's a highly treatable condition. And we've developed really effective treatments for PTSD over the last few decades. And when you work with somebody who has PTSD and you provide those treatments and you see them get better, those treatments kind of tend to work on the providers as well. So you see somebody get better and you start to, for lack of a better word, get used to the things that you're hearing from them. Because you see them get better. Now, that's not to say that everybody who works with traumatized populations is going to have that experience. That's not what we see. So some people who work with traumatized populations and really only do assessment, for example, so they're only hearing the bad things and they don't really hear about progress, or they don't really see progress. Or providers who interact with patients in not in a treatment way, but just in sort of a management way, a case management way, may often be exposed to the negative aspects of those people's stories and their traumas without the benefits. And so those folks may be at higher risk for developing problems in working with many patients with trauma histories. Okay, so an essential component of trauma-informed care is a basic understanding of trauma. Again, I want to make a plug here for our consultation program. This is a program out of the National Center for PTSD that's available to anybody who works with veterans or might work with veterans in the future with PTSD, and it doesn't have to be just VA providers. So if this is you and you don't know as much as you'd like to about trauma or PTSD or trauma-informed care, please copy this information down. We are available for you at any point. I do want to talk just briefly about removing some of the barriers to trauma-informed care around assessment and screening. In our work with people outside of VA and frankly outside of PTSD specialty care, we know that many people are concerned about screening for and assessing for trauma and PTSD. There's some of those fears I have listed here. So many people think, I don't have adequate training to assess and screen for trauma and PTSD, so I shouldn't do it. I'm not sure what to do if I find out there is trauma or PTSD or other impacts of trauma in my clients. And I certainly don't know how to do those treatments, or my focus is not on PTSD, so I shouldn't be the one assessing. And again, I would just say that removing or addressing some of these concerns that may be present for yourself or for your staff will be important if you're going to include trauma screening in your procedures. And again, that's one of the things we would recommend. We do have some instruments available online. These are free instruments available to you through the National Center. I provided the links here. If you have any questions about these instruments, please feel free to contact me. And in particular, I want to highlight the middle one, the PC-PTSD. It's a 5-item screener that's developed to be used in primary care settings. Real quickly, given that dementia and PTSD share some common symptoms, I just wanted to highlight some of those. So some things that we see both in dementia and PTSD, things like behavioral excess, agitation, aggression, delusions or hallucinations. Those things are things that we see both in both populations, and underscores the importance of assessing for trauma and PTSD in your population, so that you can adequately, attribute those symptoms to the right disorder. Okay. Again, some more information available to you through the National Center. Please look us up if we can be helpful. And finally, this is our consultation program flyer. And again, we would just say, if you have questions moving forward, you don't have to be an expert at your site. There are experts available to you, and please make use of those resources. Thank you for your attention.
Thanks so much. We'll move right to Andrea's presentation.
All right, great. Thank you, of course, to the Administration for Community Living, the Society on Aging, and the National Alzheimer's and Dementia Resource Center for this great collaboration on the topic of trauma-informed care and dementia. With that, we'll just jump right in. Seniors at Home is a division of Jewish Family and Children's Services of San Francisco, the Peninsula, Marin, and Sonoma counties, and has served the region since 1850 and met the needs of the community of over 1,000 Holocaust survivors. Here we are. We provide more than 2,800 hours of care management, counseling, and consultation services from our agency to over 300 survivors each year. I'll be sharing our program model for person-centered trauma-informed care, which is a critical component of being able to compassionately serve Holocaust survivors who have experienced these unimaginable traumas. There is a marked interplay between dementia and Holocaust-related traumas. Those living with dementia frequently recall early life, and because the Holocaust was such a forceful and horribly memorable event, for many survivors, the Holocaust becomes their present. It's important to understand clients' current behavior in relation to their Holocaust experiences. Many successful and innovative approaches in practices in dementia care may apply to those affected by the Holocaust and dementia. However, not all of them are effective. For example, reminiscence therapy, we often find a very common practice. This can exacerbate the behavioral symptoms for a person with dementia. Today we'll talk about various practices in your work and learn specific strategies to support individuals with dementia who have survived the Holocaust. It's important to be aware of what may interfere with your clinical work and what strategies will support it. It's different working with individuals with dementia who have survived the Holocaust because many of the important coping strategies for survivors of trauma aren't possible with cognitive impairment. Dementia interferes with a person's ability to process information in some of the following general areas: judgment, reasoning, communication, orientation, and a lot of the behaviors associated with these areas overlap with the PTSD criteria outlined earlier by Matthew. And then moving over to the trauma side, for example, survivors are incredibly resilient people and have relied on these very skills and abilities to cope with their experience before the dementia. So judgment, reasoning to rebuild their lives, to build community, create change, educate and advocate to be sure this never happens again, communication to express feelings, get support and help, navigate their lives, emigrate, orientation, an ability to reassure themselves in the moment when triggered and thinking about past trauma, and determination, the survivor mentality to helps them overcome the trauma. And the only thing listed here that may not be affected by dementia is a person's determination. In fact, we often see this as a strength among our clients with dementia. However, we do see that dementia affects a person's ability to have insight into their current circumstances, limitations, and of course, quality of life issues. Other factors that make working with clients with dementia and trauma different are families. Adult children are protective of their adult children of Holocaust survivors who may have been very young or even not yet born during the Holocaust suffer second-generation trauma. At times in our work, we have to revisit and be clear on who the client is, the older adult parent or an adult child who has their own set of challenges coping related to the second-generation trauma. We see many common themes among children of Holocaust survivors and their parents, including feeling very protective of their parent, having low confidence in systems, or distrust and paranoia about systems. Also, difficulty navigating and discussing a care plan in the context of their parents' complex medical condition, focusing only on surviving each phase, making long-term planning difficult. One of the largest issues we face with our clients and their families is helping the adult children understand and differentiate behaviors associated with dementia and those associated with trauma, and resisting recommendations in fear of re-traumatizing their parent. I'll give you an example here. A family might have difficulty exploring the need for placement in a skilled nursing facility despite their parents' complicated medical condition, failed attempts at other interventions at home, and a multitude of hospitalizations because they liken placement into a facility to a concentration camp or institution. In our work, we aim to support aging in place, but dementia significantly complicates this effort. And this is complicated because often we must facilitate a discussion about the risks and benefits of remaining in the home. It may be possible with added support of hospice or other in-home support, but due to the survivor mentality, a family might refuse to allow hospice in for fear of giving up. A lengthy and thorough conversation must occur to help the family understand that in some cases, with the right accommodations and adaptations, a Holocaust survivor might be well supported by placement in a skilled nursing facility, getting the medical care that they need, or by bringing in help into the home. You as the professional can facilitate this discussion and coordinate conversations with the team and transition team to adapt the plan in order to accommodate this person. We will discuss practical strategies in a few moments, but remember this scenario and I will refer back to it. Common practices and approaches to working with families that you might consider avoiding are things like therapeutic limit setting. This practice is commonly used in complex family dynamics where you must help the family or client work efficiently toward a goal. This practice may not apply here because the family may not respond positively to you if you aren't flexible in your time and work with them. Another common practice would be blaming or forcing an intervention on doctor's orders due to the experiences in the Holocaust. Many of our clients are re-traumatized by this approach, and if it isn't re-traumatization, it could just be that they simply don't feel comforted or at ease hearing these doctor's orders. And lastly, due to the complex nature of these cases, it's important to allow yourself time with these families and clients, get to know them, ask questions, and try your best not to rush or overlook an approach that may be effective. Setting firm limits on time may not allow these clients to build the trust and rapport needed in order for you to be effective. Now I'd like to discuss briefly the perspective of the family. Excuse me. Since dementia is generally a slow, progressive disease that affects the entire family for a prolonged period of time, it makes it difficult for families to reevaluate strengths periodically. And all these common observations with families are magnified for our clients who have experienced trauma related to the Holocaust. Families express an intense fear of the stigma of dementia as closely correlated to a person's intelligence and identity. Fear of stigma often prevents early diagnosis, treatment, discussion, or planning for the future. Also, dementia affects all aspects of a person's being, emotional, physical, financial. Families struggle with meeting the unmet needs in all of these areas. family dynamics in survivor families are complicated, and this dynamic, as well as other mental health issues and needs, do not go away at the onset of dementia. Instead, what we see are magnified behaviors, reactions to behaviors, and some difficulty with resenting the caregiver tasks, which are always met with resistance on some level. As we move on to strategies to support families, I'd like to bring you back to that scenario we discussed a few moments ago. When families are faced with the decision to find long-term placement due to medical needs, mood and behavior concerns, or for respite for the primary caregiver, it's challenging for them to know when it's time to make that decision. It's helpful to ask the family their perspectives and build your care plan based on that initial conversation. Flexibility is really important here. Compartmentalize complex situations. This is a step-by-step process. The issue of long-term care is overwhelming, and you must prioritize the most important elements of that discussion in order for the family to take the steps necessary to meet that care plan goal. For example, stabilizing a person's medical condition to avoid another ER visit, emphasizing that there are options and recommendations and changes to the plan. They don't necessarily have to be permanent, so just encouraging them to try an intervention for a period of time and see if it works. It's also important to have regular communication and meetings. Typically, we are taught that one family member must be the spokesperson. That may not work in these more complex cases. We're now moving into a few more practical strategies where I'll discuss the following. So how to apply best practices in dementia care, such as the person-centered approach, avoiding known triggers to prevent re-traumatization, understanding therapeutic lying, and adapting SAMHSA's 6 key principles to trauma-informed care. First, we know that there are certain best practices in dementia care that may not work for Holocaust survivors, but there are some that work quite well. For example, the person-centered care approach is critical in working with individuals with dementia. It involves anticipating needs and making sure the client's perspective and preferences are the main theme in the care plan. It's the most important to understand that not all experiences in the Holocaust are the same. You must do some research and discuss with individuals close to the client or the client themselves to gain that perspective as much as possible. Of course, there's also the importance of understanding that behavior is communication, and one must respond to the emotion behind what's being said. A good example to illustrate this is the client who's accusing everyone of stealing their personal belongings. This is likely connected to experiences in a concentration camp and having an intense fear of not having enough food, being torn away from personal possessions, and not having any privacy or personal rights. The intervention with this in mind is finding an individualized approach to address these fears. Maybe it's an open discussion about understanding that emotion. Maybe it's making sure that there are multiple versions of a valuable item. Or maybe it's a way of organizing their personal belongings so that everything is visually available to them since memory is impacted. The key here is anticipating the person's needs and understanding their perspective and making the necessary accommodations. Along this line is identifying and avoiding known triggers. Once you're made aware that your client is a Holocaust survivor, you can safely assume that you should avoid these likely triggers in various forms: doctors, lab coats, an authoritative approach, dogs, loud dogs barking or dogs around the office area, showers or talking about needing a shower, strong odors such as chemicals or bleach, sirens, loud noises. There's also triggers that we can't ever avoid necessarily, so what do we do about those, such as needles? Our best advice is not to rush through with any physical restraint. Definitely do not try to convince them why it's necessary. Do engage in friendly conversation throughout. Talk about points of interest. Do distract by offering a headset with music. Engage other senses. This is something often overlooked. Aromatherapy, other forms of touch to distract, taste, maybe provide a favorite snack. You can also schedule the appointment during the patient's best time of day or encourage the family to do so, avoiding times of known agitation or sundowning. Next, medical transportation. Find ways to avoid medical transportation if at all possible. You can schedule non-emergency transportation, talk with family members and coordinate, maybe a care manager. You can also avoid use of the word transport, instead describe the outcome. We are going to get help. You're invited to see your care team. We will go together. That language is very different than very medical terminology. If you can't avoid the ambulance, accompany the person in the ambulance and explain the situation as much as you can, history, and triggers to the paramedics. Lastly, sterile-looking environments. Consider ways to soften the appearance, integrate bright colors, flowers, art. Suggest to families that they bring a small photo album or distract by offering a favorite magazine. Again, the headset with music is often very helpful. Give them something to hold. This symbolizes security for people with dementia. Weighted blankets are also effective sometimes. And then really focus on your body language and creating a feeling of active listening and safety. The purpose of knowing these details is all aimed at avoiding or preventing re-traumatization. All right, now more practical strategies to apply in your work. Perhaps the most valuable communication tool you can provide to families, but what they struggle with the most, is therapeutic lying. Families really must hear that it's okay not to tell a person with dementia the truth 100% of the time. One way to help illustrate this is the quote from Dr. G. Allen Power, which says, "Dementia is a shift in the way a person experiences the world around them." What this means is that we must be the ones to adapt. We can't expect the person with dementia to adapt. Other helpful language to help explain this: individuals with dementia rely on others to feel safe, reassured, and validated. If they're unable to hold on to new information or make decisions independently, it is the responsibility of the family member or people around them to create that feeling of safety and a supported environment. Anticipation of needs is critical here. You must simply know what a person likes or dislikes and integrate that into your communication, discussion, and the overall environment without asking the person with dementia to provide and approve each step. I know most of you have experienced this firsthand. I've just found this particularly useful in supporting families of Holocaust survivors with dementia. Another very practical strategy to apply here is those SAMHSA's 6 key principles of trauma-informed care to patients and clients who are Holocaust survivors with dementia. With dementia and trauma from the Holocaust in mind, how can we create a feeling of safety for the client? It's important to be mindful of known triggers, as we discussed, based on the person's past experiences, and remember that each story from the Holocaust is unique, and we must take the time to explore the individual strengths and triggers accordingly. Next, adapt your approach to accommodate those needs from the beginning. For example, when working with survivors, consider not wearing your lab coat, have a meeting in a quiet, comfortable space, offer a beverage, snack, look at the environment to be sure there aren't any easily managed environmental triggers, noise, crowded, sterile appearance as we talked about. Third, show safety and support through body language, make eye contact, ask what safety means to the individual. This question instantly creates a feeling of safety and builds rapport. View trauma-related symptoms and behaviors as attempts to cope versus the negative, which is they have dementia and they're agitated. These can be seen as strengths. Lastly, having an awareness of individuals' discomfort or unease. Be in tune with body language of your patient. Change the subject or offer emotional support if you observe a person struggling during your meeting or treatment. Check in with them, make sure they're okay. With dementia and trauma from the Holocaust in mind, how can we demonstrate trustworthiness and transparency? Be descriptive, ask questions, listen and echo what you hear. I'm going to move a little bit more quickly to be sure we cover everything. Peer support. With dementia and trauma from the Holocaust in mind, how can we create a system of peer support? We found it's important to normalize the situation and integrate follow-up support in your care plan and discharge plan. Refer to a local Jewish Family and Children's Services in your area, research programs available specific to your region, and make a direct referral connection with consent of the family. It's important to coordinate with a family member or friend, outline goals of the referral to the next program. Providing a warm handoff is important. Collaboration and mutuality. With dementia and trauma from the Holocaust in mind, how can we create a feeling of collaboration and mutuality? Making sure that family members are on board, strengthen existing support systems, provide a lot of education about the difference between the behaviors associated with dementia and those associated with the trauma and life experience. Lastly, empowerment, voice, and choice. This can be difficult with someone with dementia, but I want to encourage everyone to ask questions and listen to the person with dementia and find out their perspective, and then you can integrate elements of that conversation into your care plan and discuss it with the family. An example of this is asking the person with dementia, what's the most important part of your daily routine, or what brings you the most joy? Listen and create a feeling of comfort and trust, and model this for the family. Lastly, cultural, historic, and gender issues. With trauma and dementia in mind, it's important to integrate sensitivity and understanding a person's individual experience. So we covered a lot here. The things I want you to take away from this webinar is that not all Holocaust survivor experiences are the same, and thus there's not a standard approach to the care and support they receive. It's really important to use descriptive terms that your clients are comfortable with, like advocate or care partner, and avoid terms like caregiver or case manager. Let's see. We talked about current best practices in dementia care, avoiding known triggers, and definitely the best examples of anchoring safety are asking what safety means to the individual, viewing trauma-related symptoms and behaviors as attempts to cope, evaluating the environment where the treatment is taking place, and ensure it's conducive to feelings of safety and comfort, having an awareness of their response to your treatment. And we learned 3 ways to support family members of Holocaust survivors in order to gain participation in the care plan. Education to family members about common best practices in dementia care, such as therapeutic lying. Apply trauma-informed care principles, cultivating a strong system of support for your client. And lastly, understand the complexity and background of family dynamics of Holocaust survivor families and work to adapt and accommodate individual needs. You will all receive, along with a copy of this presentation, our most popular tip sheets funded by Jewish Federations of Northern America, providing step-by-step patient-centered trauma-informed care guidance for various dementia-related topics. So look for those in your follow-up email. Thank you all so much for your time, and with that, I think we do still have some time for some questions for Matthew, Yoder, and myself.
Great. Thanks so much to both of you for your presentations. They were fantastic. We did have some questions come in while you were speaking, so I'm going to get right to some of those, while others are welcome to enter additional questions into the chat feature of the webinar. So one question, this would be for you, Matthew, the question about if there's an increase in PTSD symptoms late in life, would that also be an indicator to assess for dementia?
Well, you know, that's a good question. I think not necessarily, but if you look at the costs of doing an assessment like that, again, if it's woven into the practices at your site, and there's not a lot of cost in doing that assessment in terms of time and resources, I think it certainly would be worth your while. But I don't think, you know, we want to equate increases in symptoms of PTSD with those with increases in dementia.
Okay. Another question, if there are any psychotherapy techniques for PTSD that have also been proven to be effective for people who have dementia?
Yeah, great question. So I mentioned that we do have some very effective treatments for PTSD. Two of the most studied treatments are prolonged exposure and cognitive processing therapy. And both of those treatments have been used with patients who have co-occurring dementia or other neurocognitive disorders. So both of those treatments would be recommended. Now, all of that research has been done on patients who have mild to moderate neurocognitive disorders. So, for example, if the patient can't remember what's talked about in the previous session or doesn't have the resources to do homework in between sessions, those can be very real barriers, and we really don't know whether the treatments are effective in people who have severe dementia. So, but other than that, yes, mild to moderate dementia, both cognitive processing and exposure therapy, prolonged exposure therapy would be recommended.
Great, thank you. Andrea, we have a few questions about therapeutic lying. In particular, a few folks have asked if you could give an example to kind of describe what you mean and how it might work.
So sticking with our example of navigating changes in care, so looking for placement, families often ask me, oh, well, we promised her we would never place her in a nursing home or in assisted living or memory care. And what I encourage family members to do is, as it relates to therapeutic lying, is maybe describe it, because the person with dementia is usually unable to use that abstract thinking, and so assisted living or a new foreign place is very upsetting to them, but maybe a handwritten invitation of join us for a sing-along at the community, and then talk about just temporary placement and being a lot more descriptive about it. That's a form of therapeutic lying. Another quick example is the person who asks where their mother is pretty frequently, and what we train our approach here on this is to not remind the person that their mother passed away. That sparks feelings of, oh my gosh, new feelings of grief. I should have known this. Why am I forgetting? Why did I not know that? And then increased disorientation and anxiety about that. So we learn about various influences and philosophies, but it's important to think about the emotion behind what's being said. So mother symbolizes feelings of safety, familiarity, comfort, security, and so we try to exercise therapeutic lying and maybe talk about their mother, or say, something briefly about their mother. Their mother loves them very much, and then distract and use other ways to engage other senses.
Another question for you, Andrea. So someone asked if a Holocaust survivor who has dementia is experiencing a memory of a concentration camp experience, how you proceed, since they mentioned that trying to reorient someone with dementia is typically not what they try to do with disorientation to time and place. What do you typically recommend?
Definitely. So that looks differently depending on the individual. Some of our clients feel very comfortable talking about it and teaching others about their experience. So if they're having, a major period of increased anxiety, thinking that they are in the concentration camp, you can engage in a discussion with them about their life and attempt ways to distract, but really most of it needs to be nonverbal. So demonstrating feelings of safety, security, and staying with them, and meeting them wherever they are, and definitely not reorienting them to the current year and trying to convince them that they're in a different place. And really the approach there is a more validation-based approach.
Great, thank you. Matthew, for people who have experienced trauma early in life but maybe were asymptomatic, is there any research out there that talks about concerns regarding the development of PTSD later in life if they develop dementia?
Yes. Well, again, those connections between PTSD and development of dementia, or perhaps even in the case you're describing, like sort of undiagnosed PTSD, they're somewhat unclear. We do know that many patients who have experienced trauma, that those symptoms can be undiagnosed or dormant or not as impairing throughout their life, and then later in life, for various reasons, can kind of come online. So, we see that happening when about the time when people retire, when people have more time on their hands, and when their sort of strategies for avoidance aren't as readily available. And I certainly think that would apply with dementia as well. So if somebody has a history of trauma and is managing those symptoms adaptively or not throughout their life, and then starts to develop dementia, some of those inhibitory mechanisms, strategies may not work anymore. And so I certainly think developing symptoms of dementia would put someone at risk for developing PTSD if they have a trauma history.
Great, thank you. Both of you may be able to answer this briefly before we have to close out, but someone asked about, are there any studies, or is there anything you've seen in your practice that indicates someone's cultural background may affect their trauma symptoms or may lead to various different types of trauma symptoms? Have you seen differences in various cultures or how they deal with the trauma that's being experienced?
Yeah, so I can just say real quickly that yes, how people's culture and the way trauma is conceptualized in their culture can significantly impact how those symptoms of trauma are displayed and what you might see. So we certainly don't have information about all cultures out there and then what trauma reactions look like in those cultures, but in general I would say yes. And so being aware of someone's cultural background is extremely important, and I would include military culture in that cultural background assessment, just to sort of be aware of how their culture, whatever that may be influencing their symptoms.
Great, thank you. Well, we have run out of time. I want to thank you both for your excellent presentations in response to so many questions. I will save the remaining questions and forward them to the presenters so they can respond to as many as they can. And Steve, do you have any closing remarks?
Yes, just wanted to thank everyone for joining today's webinar. We appreciate it.